हाँ सब बात हो गई ठीक है
Kindly let us know when to start.
Start, Prashant.
So I welcome you all, and I would request now from Lokesh Ganju from marketing team just to share a glimpse of about Mankind Pharma. Lokesh.
Thank you, Dr. Prashant. So, good evening to all of you, and very welcome for this post EASD highlight. So, I'll just rush through the corporate presentation, and then we can continue with the. Am I audible, Dr. Prashant?
yeah but there's some
Yes, Lokesh.
staggers in the voice
Some lag is there. There's some lag.
Mhm.
Okay. Is it okay, Dr. Prashant? Can you please
Yes, yes.
confirm?
Now
Yeah,
it
yeah.
is okay.
Okay. So, Dr. Ruchika, can we start now?
Yes, sir.
Okay.
I think you could start, no, Mr. Ganju?
I'm just waiting for the confirmation. Dr. Ruchika, can you please confirm whether we can start if we have gone live?
Yes, we are live, sir. Please start.
Okay, thank you. So, a very warm welcome to all of you, and a very good evening to all of you for sparing. And thank you so much for sparing this time for this program, that is EASD highlights, post EASD highlights to be more precise. And let me start with the corporate presentation of Mankind. So, we're all 2020 is the year when Mankind has already completed 25 years in the Indian pharma market, and obviously, this could have never been possible without all of your support. So the vision of the company has always been to be the most admired Indian pharma company, and we are really striving hard to be the same. And as far as mankind's values are concerned, it is actually serving life. And as far as the ranking in the pharma market is concerned, we are ranked 1 in terms of prescriptions, and we are ranked 4th in terms of value-wise, value generation in the market as far as MAT value is concerned. And we are already present in 34 countries with more than 300 products and more than approval from more than 13 regulatory bodies. And we have 19 world-class US FDA and WHO GMP compliant manufacturing. And besides this, during this tough times, we really, as in Mankind, salutes the true heroes, that is all of you who are attending this meeting. And during this tough times, there are few contributions which we have done as far as corporate is concerned. Number one, we have been able to contribute 51 crore in PM Care Fund during this COVID times, and as an employees of Mankind, we have contributed 1 day salary of ours. And besides that, we have been able to distribute a lot of protective gears like PPEs, masks, and all these things like sanitizers and all. And Mankind, actually, our commitment is to improve quality of life, and it is based on 3 pillars, that is affordability, reach, and quality. And as all of you know, that Mankind is known for providing affordable medicines. So we are really striving hard to make it available, make available the affordable medicines at any cost. And our reach, we have the largest number of field force, and have been able to reach each and every nook and corner of the country just to offer the affordable medicines at the best quality possible. And we have a strong presence across various therapies like anti-infectives, gastrointestinal, cardiovascular, anti-diabetic, and so on. Leadership in many of them. And Mankind has a well-established R&D center at Gurgaon, Manesar. There are major capabilities are like new drug discovery and research, API development, formulation development, biosimilars, clinical research, and so on. And it gives me really immense pleasure to announce that we have recently been able to complete the preclinical trials of GPR 119, which is a G protein coupled receptor molecule for diabetes, and we are already working on establishing few molecules like JAKstat for rheumatoid arthritis and PCSK9. And as I said, during these tough times, mankind has been able to contribute in terms of contribution in terms of PM Care Fund. We have distributed more than 15 lakh masks, more than 12 lakh medical equipments, more than 12 lakh sanitizers, and more than 1 lakh PPE kits. And obviously, all these achievement endeavors could never have been possible without all of your support. So we just look forward for your continuous support and encouragement, so that we keep on doing such endeavors. And we are really thankful that you all have come for this meeting today. Here, I would like to hand over the session to Dr. Prashant. Dr. Prashant, over to you.
Thank you, Lokesh. And hello and good evening, everyone. At the outset, I, Dr. Prashant Agarwal, on behalf of Mankind Pharma, welcome you all today to this panel discussion on highlights of EASD meeting 2020. We have an esteemed panel of eminent diabetes and endocrinology specialists in the discussion today. We thank each one of them for agreeing to share their insights with us on the latest developments in the field of diabetes. So let me introduce you our esteemed speaker for this panel discussion first, Dr. Amrish Mittal, sir. Dr. Mittal is the chairman and head of endocrinology and diabetes at Max Healthcare, which is a part of Pan Max, a group of 16 hospitals. He is the domain expert on the governing body of National Health Authority of India and President, All India Institute of Medical Sciences, Gorakhpur. Welcome, sir. Now, Dr. Shashank Joshi, sir. Dr. Joshi is the chair of Diabetes Federation, Southeast Asia, Dean of Indian College of Physicians and endocrinologist at Joshi Clinic, Lilavati Hospital, Apollo Sugar Clinic, and Bhatia Hospital. Welcome, sir. Dr. Vipin Kumar Sethi. Dr. Sethi is the consultant endocrinologist at Care Hospital, Hyderabad, and professor of endocrinology at Gandhi Medical College, Hyderabad. Welcome also, sir. Dr. Sujoy Ghosh. Dr. Ghosh is the professor in Department of Endocrinology at Institute of Postgraduate Medical Education Research, Kolkata. And welcome you, sir. Also. Now, a panel discussion is not complete without an equally competent moderator. And for that, we have Dr. Rajiv Kovil, sir, to moderate the session. Dr. Kovil is the medical director and consultant diabetologist at Dr. Kovil's Diabetes Care Center and consultant diabetologist at Nanavati Super Specialty Hospital, SL Raheja Hospital, KLS Hospital, Arogya Nidhi Hospital, and PSES Hospital. He is also the invited faculty at the Diabetes Fellow Program at DY Patil Medical College. Welcome, sir. And we hope that our audience gains insight into numerous ways, new topics in diabetes management through this wonderful panel discussion today. And this event may inspire ideas and discussions on better patient care and diabetes management. Now, with this, I hand over the session to Dr. Rajiv Kovil, sir. Over to you, sir.
Thank you, Mankind Pharma. Thank you, Dr. Agarwal, for this warm introduction to all our speakers. It's less than 18 hours that the EASD has ended, and here we are in less than 24 hours discussing what were the highlights of the EASD. That's like breaking news which occurs every evening on our TV news networks also. And patients keep on doing doctor shopping. And here we have 4 stars across India who are going to ask one question, and you're going to have multiple opinions on it. So, I'll start off with you, Sujoy. Remission versus reversal of diabetes. Now, it's been 2 years since the direct study, and people in India talk about reversal or whether it's a remission. And so there was some data presented that the pancreatic morphology almost became normal. So can we call these patients in the direct cohort as being reversal or well-controlled diabetes?
Good evening, and a big thank you to Mankind for having invited us onto this panel discussion, and good evening, Rajiv. I think you've asked a very, very difficult question because we honestly don't know. We'll actually have to wait. And big congratulations to Roy Taylor and his group from Newcastle, because in the last couple of years, they've actually followed up the data of the direct study, wherein, if you look at people with diabetes, they have advised intensive dietary interventions and made people lose weight. Now, we know that one of the major challenges and the problems of diabetes is weight gain. And say, for example, whatever your baseline BMI was, once you're an adult, thereafter you put on weight, the first place that the weight goes to is perhaps the liver, and then to the other organs. And an individual who's genetically susceptible in such a scenario will develop diabetes. And there have been beautiful studies published in Diabetologia, which also show that not only in the liver, but also the pancreas also becomes bigger and there's more pancreatic fat as well. MR sequences have shown that. And if you look at direct study, the first thing that happened was people started losing weight from the livers, and their blood glucose levels seem to improve in the diabetic population of the direct study. And now this is actually an extension of that particular study, which shows that even the fat from the pancreas might have disappeared. The pancreas has become smaller, and the margins of the pancreas have also improved. The morphology have improved. Now, that could probably be because of the amount of extra fat that got into the pancreas and made it work badly has got reversed. That's one possibility. The other thing is, the body's insulin levels might have gone down, because the better your diabetes is controlled, your insulin sensitivity improves and your insulin secretion goes down. And that could well be because we know insulin is trophic for everything in terms of growth. So that itself might have made the pancreas not be as big as it was before. So that could be one other possibility. Now, when we talk about remission and reversal, these are very technical terms. Someone's blood glucose was high at some point of time. You've done whatever it is, weight loss, bariatric surgery, and whatever, and you find that the blood glucose is normalized. Remission, on the other hand, would be something I would think, complete. One is temporary and the other is absolutely complete, absolute reversal. You might be in partial remission for some period of time. Now, I would suspect diabetes is going to come back in, if not all of them, at least in some of them over a period of time. Because, it's not one pathophysiologic abnormality that happens. And the body weight might have triggered the underlying problems. Now that you've got rid of the fat, reduced weight, some of that has gone. Maybe some of them will again have the diabetes at some point of time. That's number one. And even if you look at the direct study per se, not everybody had similar responses. People responded differently, clearly telling you that you're dealing with a heterogeneous, complex disease and not, a single tick box kind of a disease. So I suspect it's going to come back, if not in all of them, at least in some of them over a period of time.
Thank you so much, Sujay. Dr. Mittal, your comments on the pancreatic morphology getting better with weight loss?
So I think the pancreatic morphology study is interesting, and I would leave it at that. I think the causality is hard to establish at this stage, but definitely it's an interesting finding, because first you have to show some kind of correlation, not just a finding, a correlation between pancreatic morphology and degree of hyperglycemia, severity of diabetes, duration of diabetes. No one has done those kind of detailed studies, although there are very interesting studies, but they're mostly cross-sectional and all. So I think this is a very interesting finding. I will just make a couple of points in this regard. Yes, quite clearly, and we all have patients like that in the real world. There are patients in the early stages of diabetes whose diabetes is clearly brought on by a bad lifestyle or just weight. And in such patients, if they are motivated enough to lose a substantial amount of weight, then the diabetes can go into remission. Whether it's temporary or permanent, I have no idea. But the truth is that I have patients who are 15 years, 12 years in remission. On the other hand, this is a small proportion of the patients that I see. So the first is that the challenge in weight management is always to maintain weight. The initial weight loss can be affected by various approaches, various techniques, but even following bariatric surgery, which is the most sort of radical way to lose weight, even there, the tendency for the weight to come back on exists. And in most weight management programs, as this expert group knows very well, you lose weight for the first 6 months, 1 year at the most, and it starts, then rising again. It's very hard to maintain. And 2 points here taken from direct study itself. If you look at 1 year, 2 year data, both are very impressive. The 10 kilogram weight loss, 15 kilogram weight loss is like 75% or something remission. Uh, but between 1 and 2 years, there is a difference. There are greater number of people in remission at 1 year. Some of them, some proportion, is already going back up uh, uh, by the time it's year 2. That is one important point to remember, that it's hard to sustain. They've done a fantastic job, amazing job, these researchers, but still hard. The other is that the diet that was used to induce that degree of weight loss. I mean, every patient will walk in and say they want to reverse their diabetes. Try and make them follow 800 calorie diet, and maybe for Indians it probably be 750 or something, or 700. I mean, it is going to be like it's very hard to follow those kind of diets. So the caveat is the diets are very hard to follow. Weight loss is works for sure. There's no question, but it is not that easy as the study makes it sound sometimes, because reading a study you get carried away. Third is that the challenge will be to sustain the weight loss or maintain the weight. And only then, if we're really able to maintain the weight, we might see that there are people who are in complete remission forever. There will be some weight gain, I suspect, but even if that can be kept within reasonable limits, probably our patients can go on very long. Again, before I close out, the important point will be that not all patients are the same. It's a complex disease with multiple pathophysiologies. There are patients, and now with precision medicine and the talk of personalized medicine, the defect may not be exactly the same in everybody. A overly simplistic concept of everyone getting resistance, Starling curve of pancreas failing, and beta cell failure is a very good model, but it's not universally applicable. So all those factors have to be kept in mind.
Thank you so much, Dr. Mittal. And we go to Dr. Joshi, whose weight has been maintained for more than 2 decades that I have known him. So, Dr. Joshi, your comments on the direct studies and the morphology.
I think Dr. Sujay and Dr. Mittal have very elegantly cited whatever one can think of remotely and granularly. I have just to make just a little bit of dilation of what they have said. Remember, real world studies and real world is very different from RCT world. Remember, a large group of the direct group was a radiology MRI group, and they were very good at morphological mapping in vivo. But remember that some of these RCT evidences, as Dr. Mittal said, 700, 800 calorie diet is near impossible to be sustained, persistent, and over a period of, the largest trial in the lifestyle space has been the Look Ahead trial. And after almost 8 years, due to futility, NIH gave up because the control group caught up with the regular group. So remember that lifestyle works in early diabetes in the first 6 years. So if you have duration of diabetes is less, it works. Diabetes is a very heterogeneous, multi-cluster disease, as a lot of clusters have emerged. And drastic weight loss diets have always worked. So it's basically a simple caloric reduction. It is reorganization of pancreatic fat, liver fat being remodulated. And it is like a medical bariatric option. I think the good thing from it is that surgeons were lost all their surgical skills when we were medical students. Vagotomy used to be done for peptic ulcer, and I think with the advent of H2 blockers and PPIs, I think the surgeons went out of business completely from that space. Suddenly they realized that they became bariatric surgeons. Bariatric surgery was not that attractive because morbid obesity is a challenge. So they decided to get into metabolic surgery and they started doing this remission of diabetes. So I think I congratulate the direct group. They have put endocrinologists back in focus and they have shown that lifestyle is as good as bariatric surgery. So from that standpoint, if you ask me, it is a very elegant piece of work which is reproducible, which is in the guidance now, EASD guidance has put there, and it is doable. And it is done in an evidence-based fashion. Right now, you see there is quackery in India, and there are pseudoscientists, anecdotal evidence, and each person has his own diet. So all Babas to various other people, I don't want to cite here, but everybody has their own diet. So like we have some of them in Maharashtra, some of them in Bengal and Delhi. We all see this. So I think this is an evidence-based way for remitting diabetes and losing weight, and it is very good for short term. It is very difficult to maintain, but I think if we can design, and it gives us a motivation to design a pragmatic real world evidence based trial, multi-center, in an Indian population which is reasonably rebellious in many ways when it comes to lifestyle, and is very proactive only based on situations. For example, if there is a motivation that in 2 or 3 months there is a wedding coming up, then they would love to do it. And therefore, in these situations, these are very good motivational tools. So I think I would take it in a positive way, and I think we have something on board. It at least tells me that somebody who is eating 3,000 calories, at least I can tell them, at least make your diet half, and it will work. And when you give that caveat of reversal, people tend to get conned into it. So this is not a con phenomenon. This is done by scientists. And therefore, I think it's a very good thing for endocrinologists, diabetologists, weight loss experts, all doctor community at large, because this space, surgeons try to invade it, and then quacks try to invade it. But I think it belongs to the medical physician bed, and I think that is where it belongs. So I think it's a very good thing, and we should put science, and the morphology makes it very attractive. See, the visual impact is very high. So Dr. Mittal is a fantastic photographer, and I think Sujay is a very good illustrator of education. So I think the right thing is that you have a tool to motivate patients. I see it from that point. And that's why the morphological expression of the beta cell changes, alpha cell changes, fat going out from fatty pancreas. You see, when you talk of fatty pancreas, fatty liver, patients get very excited and they tend to cooperate. So I think I see it from that standpoint.
Thank you so much, sir. Dr. Sethi, your views on it?
Well, a very simple thing that, as everybody said, it appears doable, but it is extremely difficult and hard to maintain. What we are doing possibly is just rewinding the clock. And if the factors which cause the decompensation come back, then the reversal is not going to be there. So, but as a concept, it's attractive and possibly can be implemented. It has been done earlier for prevention of diabetes. Now we are doing it for treatment of diabetes. So I think this concept is attractive. And as everybody said, looks doable, but hard like any other diet program. But it can certainly offer some hope to people who are very, very good and who are going to be compliant. That's all that I have to say.
Rajiv, can I come in for just a second before you close out this topic? One is that in the direct study for 16 weeks, up to 20 weeks, I think they were on actually meal replacement. Again, good to know. They were on meal replacements, and the calories, that's how were maintained. After that, they were on maintenance diet. So it is not that for 2 years they were on that 800 calorie diet. That's just good to keep it. The other one is that in our study DLIFT, which just got published, the reduction in pancreatic fat was not seen with dulaglutide. Based on the EMPA thing, we were excited. Maybe we'll find pancreatic fat reduction. Short study, 24 weeks, but we did not see any reduction in pancreatic fat with the use of GLP-1 RA in this short period. Pancreatic fat was done by the best possible magnetic resonance technique. And the last point, which I would like people to comment actually, is that there's this whole thing about Indians not being really fat. And these studies will not apply to Indians. That is also coming. A lot of people are sending me, but Indians don't have obesity. I don't know. Compared to the environment and work I worked in 20 years ago to now, I think most of the patients I see are clearly overweight or obese, and they would all benefit by weight loss. Any comments from others on that?
I completely agree that I think we are thin fat Indians. Our body fat has huge composition of fat. It may not be cosmetically looking morbidly obese, but that doesn't qualify us not being, having adiposity within us. And I think that I completely, and I'm sure Sujay was, I'm sorry, I think I interrupted him. He had to make a comment. But I completely agree with you that, even someone like me has a lot of fat in my body, which is quite surprising for my BMI. So that's the whole thing which Dr. Yagnik has very illustrated in that thin fat Indian with Yadkin and Yudkin. So I think we clearly have that. And I agree with Dr. Mittal that actually a little bit of fat loss is more relevant than weight loss also.
I think we need to redefine the way we define obesity.
Absolutely.
That's the most important thing. These anthropometric parameters, whatever we use, whatever different cutoffs we use for Indians is not the way to actually assess obesity. Body compositions and body fat proportions will actually have to be measured before we say someone is fat or not fat. I was just before the program speaking to Rajiv that I now have a cohort of young women with polycystic ovarian disease, one group where you would actually define them as either overweight or obese, and another group of polycystic ovarian disease which you would not define as overweight and obese, and similar BMI women without PCOD. So essentially I'm talking about 4 groups of individual, and we've looked at their body fat, we've looked at their liver fat, we've looked at their insulin resistances. It's clearly different. The ones who are diseased have much more body fat compared to the ones who are not diseased.
Thank you, Sujay. So I consider myself as having metabolically healthy obesity. So going further, Shashank spoke about the tug of war between endocrinologists and bariatric surgeons. But SGLT2s, there have been a tug of war between cardiologists and endocrinologists for the last 5 years. And suddenly now the
nephrologists.
That's what the nephrologists have now jumped into the ring. With DAPA CKD, they have become the front runners or the flag bearers of SGLT2. Now, do you think there will be a correction in the eGFR, and how safe are these SGLT2 inhibitors in chronic kidney disease? Do we think we can use it to 25 eGFR? Dr. Mittal, you to start off with.
I think they can be used. There are some caveats we need to remember. When we are talking of using them at low eGFRs, we are talking of their role rather in reducing progression of kidney disease, microalbuminuria, and possibly cardiac protection. So that is the goal. We are not really talking of them as very serious anti-hyperglycemic agents because their efficacy drops significantly in terms of blood glucose lowering as the eGFR declines. So that is one point to understand. The other point to understand is that in our excitement, sometimes, these patients may not be eating well. Some of them may be emaciated almost, maybe, lean. Some of them may be having electrolyte issues. So we can't just throw it blindly into the mix like that. I think they have a role. They might be used carefully. It's fine to reduce the eGFR cutoff, but the role or the usage of these medicines still will have to be done carefully. I mean, I'm still careful with these medicines. Remember that if somebody with CKD gets a UTI, that can just completely throw everything off. A single UTI and that kind of prone individual can keep them in hospital for, it's how serious it can be. UTIs don't respond to oral antibiotics anymore. So that's the issue. So what I'm saying is, yes, for their so-called pleiotropic effects, or whatever you call them, the effects on kidney disease progression and on heart failure, they can be used at a fairly low eGFR also, but we have to keep all these points in mind.
Thank you so much, Dr. So Dr. Sethi, your comments on the usage of SGLT2s in CKD?
Well, I think we have some reservations, but we also have to see that there's nothing much that is available at this point of time except RAS blockage. Finerenone data is yet to come. So whatever we have, we are in a situation where we are not able to modify the basic disease. And anything that comes, whether it is canagliflozin or dapagliflozin or finerenone tomorrow, add some hope. With every drug that you have, you're going to have some limitations and you have to look at things. But I think in a scenario where there is nothing much available, this is a good hope. We are now, as Dr. Mittal rightly remarked, we are not looking at an indication for glycemic control. Therefore, the cutoff that we use for patients for glycemic control, that we will not use it till GFR 45 for most of the agents, are valid for glycemic control. In these situations, and maybe tomorrow for heart failure, when we are looking at, we are using them for organ protection. So there are two different scenarios for glycemic control versus giving organ protection in terms of heart failure, in terms of the renal protection, and in terms of maybe or may not be ASCVD. So I look at it positively, and as in anything, as Dr. Mittal really said, we have to select our patient, but there is hope that you will have some good results. And also, surprisingly, the renal associated adverse events, including hypokalemia, were actually lower in this cohort. So that is also a good thing. That means one has to be cautious, one has to be prepared for an initial decline in GFR. One has to also omit it whenever there is a reason to omit it, like dehydration or any systemic infection, COVID or non-COVID. That word has to be uttered in every meeting unless the meeting is not complete, like the EASD chart nowadays. But I think it's a good drug to be used, and we are extending from glycemic control to cardiac protection to heart failure benefits and now to renal benefits. I think that's something good about this.
Thank you, Dr. Sethi. Dr. Joshi will now tell us how he can get SGLT2s back into the endo-diabeto fold.
They will always stay with them.
They will always stay with that.
I don't think there is any challenge there. I think all outcome trials from 2015, starting with EMPIREC, taught us two things. That these drugs work best in the severest cases. So more severe is the case, the better is the outcome result. That is what these trials have shown us, whether it is heart failure endpoint, kidney endpoint, whether it's heart failure endpoints. But later on, we have got data. This is what I'm talking from EMPIREC. Now, 2020, what EASD has taught us with DAPA, CKD and other data, that they can be used at any time. The question related to eGFR will always remain that, remember, every drug insert of an SGLT2 inhibitor says acute kidney injury can occur, and can occur when it is started initially. That's something which we need to factor in. Second thing is that any GFR which is below 45 or 30 can have a detrimental effect, sometimes 1 in maybe 100 cases, 2 in 100 cases on the renal issue. Third thing is a point which Dr. Mittal and Dr. Sethi both highlighted, that infections, whether they are mycotic or bacterial, are still challenges. And if you get it, you had it. And the last thing is that I think nephrologists love to use drugs with minimal nephrons or zero nephrons. And, whatever little residual nephrons, they call it, are left over, they want to salvage them. So you will see that eGFR came down for metformin, eGFR has come down for ACE and ARB. And I think for SGLT2 inhibitors, they will definitely lower it down. I mean, between 15 to 20 is where they will look at using it. I really don't think, the best impact of these drugs still will be between eGFR between 45 and 30 for its optimal effect. Below 30, I really doubt whether it really will have a very high translational effect. And also remember that what we see in a RCT, when you move it to a real world, necessarily it may not translate for that given case. Because, diabetes care is all about individualized care. And that's where our role comes in as endocrinologists, as diabetologists. And I think, therefore, these drugs will still be in our domain. And I think, when it comes to glycemic control or for organ protection.
Thank you so much. Dr. Sujay Ghosh, your views? You have to unmute yourself. Sujay.
I'll try to be the devil's advocate. I think primarily this group of drugs is a nephrologist drug. And I have reasons for that. The drug primarily works through the kidney, and it's the renal benefit which actually gives the heart failure benefit. So if you look at drugs like, say, saxagliptin, where you had bad heart failure, was because probably it was doing something at the level of the kidneys. So SGLT2s, I think, predominantly help out the kidneys, therefore improve heart failure, and therefore improve heart failure-related arrhythmias and sudden cardiac death, and has got nothing to do with atherosclerotic cardiovascular disease. It's just that the heart failure and the arrhythmia-related sudden cardiac deaths have been prevented. And if you look at at the selection of patients in the various SGLT2 trials, you probably had more people with heart failure or underlying bad kidneys in the so-called secondary prevention cohort. Whereas in the primary prevention cohort, they usually tended to have better kidneys, less of heart failure, and therefore you did not have the reduction in the sudden cardiac death. So if you look at, for example, a trial like DAPA heart failure, DAPA CKD, Emperor reduced, in that you will see that the heart failure has improved dramatically and the cardiovascular death benefit has also happened. But you might then wonder and say, then why in Emperor did we not have that benefit of heart failure related deaths? Now, ASCVD and heart failure are two different kinds of diseases. For example, if it was truly working on ASCVD, it will be preventing only the more severe people. So people who've already had a heart attack, you're more likely to prevent a heart attack. Heart failure is not like that. If you have someone who's way down in the disease of heart failure, whatever therapy you give, you're not going to improve things. For example, somebody with an ejection fraction of 15, 20, whatever therapy you do, you will not be able to improve outcomes. So if you compare Emperor with, say, for example, DAPA heart failure, the reason Emperor did not get that cardiovascular and all-cause mortality benefit is probably because Emperor took sicker patients. That would be my take. As far as the kidneys are concerned, for the first time in almost 20 years, we now have a drug in addition to the ACE inhibitors and ARBs. And secondly, you have a drug which works even in non-diabetics. So the new trials of the SGLT2s are going beyond diabetes. As an endocrinologist, we should be proud that we've given the more so-called more intelligent cardiologists and nephrologists a drug to boast about.
Thank you. That was a good closing statement, I would say.
Very good.
So we go on to the flavor of the year, which has actually threatened our existence, on COVID-19, diabetes. And I don't think if orthopedic societies have COVID sessions, so EASD obviously had a COVID symposium. And I'll direct it to Dr. Joshi. He's been on the task force for COVID in Maharashtra and has seen it on very close quarters. So do you think that they are now saying that diabetes is not only a risk factor for adverse outcomes following COVID, but also people are getting more infected if you have diabetes? And the impact of statins. There seems to be reduction in mortality if you're using statin in COVID patients. So what's your take, Dr. Joshi?
So I think, in the diabetes space, clearly, if you just look at Mumbai city, Mumbai city has more COVID than whole of China. So our publication output is 100th or 1,000 that of China. That is the tragedy because of database and the sheer numbers which have overwhelmed our healthcare systems. Even today, you'll not believe it. Whole night yesterday, I was struggling to get beds for my patients. So this is the challenge which COVID still even now poses. Maybe Sujay is a little luckier or Bipin, but I think Amrish in Delhi also may have, in similar.
Absolutely.
And this is the challenge. So let me get into diabetes and COVID. In Mumbai city, we just looked at mortality. Number one is hypertension. Number two is diabetes. Very clearly there. And in the comorbidities, 51% of Mumbaikars who died from COVID from day one to now, it was hypertension, and 50% was diabetes. So that's a very large proportion of the population which has diabetes. And Dr. Mohan did this elegant ICMR in-depth study in the Mumbai cohort. The general prevalence of diabetes is 15%, hypertension is 30%. So if you look at general prevalence of hypertension and diabetes from the data published around 10 years back, and then you move into the COVID space, diabetes actually has an amplified, severe disease and mortality in sheer numbers. If you just pick up the sheer numbers, diabetes definitely leads to a severe version of COVID. Whether diabetes per se is a COVID risk factor is still an unanswered question. I know it's very controversial, but it's still an unanswered question. Because if you are a well-controlled diabetic, independent of age and independent of other comorbidities and independent of obesity, whether it would really have that amplifying effect, we don't know. So that's still an unanswered question. And I don't think EASD gave any insights into that. Clearly, more severe COVID, higher mortality or higher morbidity more likelihood to need more oxygen, more likelihood to get more hypoxia, more likelihood to get a longer ventilator time, longer length of stay, longer need for oxygen. All these factors are clearly there. Response to therapy in diabetics on the various research mode therapies. I don't think there is a single therapy. Everything in COVID is experimental. With diabetic population, the response is weaker or poorer. So these are clear things. Anti-diabetic drugs now are being looked at, repurposed drugs in COVID space. Whether it is metformin, whether it is gliptin, whether it is even a SGLT2 inhibitor like DAPA, they are being repurposed. And we don't have data on that, but very likely metformin will have an impact. Probably gliptins might have an impact. Possibly I am very excited to look at the DAPA trial, which might also have an impact in some degrees. And I agree with Sujay that it's a kidney drug. These are smart diuretics and much more than what they say. Endothelial effect, because a lot of COVID with diabetes is endothelitis. And therefore it's a coagulopathy, but there's thromboinflammation. And in diabetics, there is already pre-existing in non-COVID space thromboinflammation. And which is why most of our diabetics in type 2 diabetes space already are on a low-dose aspirin and statins. And that is why whatever we saw is translated evidence that statins probably might have a role to reduce morbidity and mortality in the COVID space with diabetes. So I think this is something which is known in the non-COVID space, is getting documented in a COVID space. So I think statins and low-dose aspirins, in fact, in our Maharashtra protocol from day one have been there, because we knew that our comorbidities are higher. And I think we need to continue that. And that's what EASD has only shown us through evidence. We still are in research mode in COVID, but diabetes is a huge problem in India. We are probably the second largest country in the world with diabetes. But in terms of prevalence, Middle East is much more than us. And they have not seen in their COVID space diabetes up the pecking order. United Kingdom has seen it very high in their pecking order. The underprivileged populations in United States have again seen diabetes up in their pecking order. And in India, clearly we are seeing that. The other challenge with COVID and diabetes is a lot of use of biologics and steroids. And therefore, the very high hyperglycemia as you get in week 2, week 3 of COVID space. And I'm sure all the panel members will agree with me that hyperglycemia, post-COVID diabetic hyperglycemia, which is often tending to, near ketoacidotic-like situations or hyperosmolar state-like situations, is not unusual. And the need for high doses of insulin also is not unusual. So that's my take on COVID and glucose and diabetes and statins. But I think, statins, it is prudent common sense that if you have a cardiometabolic or any vulnerable group which has hypertension or diabetes, keeping them on a low-dose aspirin with statin, or sometimes in the second week a NOAC and statin might be an order of the day in the future.
Thank you so much, Dr. Rishi. Dr. Sethi, your comments on what was presented in the EASD symposium?
Largely, I would concur. There was a study which said that pre-operative use of statins decreased post-operative cardiac events in general population. So if that is the benefit that can occur in a general population pre-operative administration of the statin, then in a situation where you have got some prothrombotic stage, you've got inflammation going on, it is plausible that it might be helpful. But while I say so, there are studies either way for every molecule. If you remember what was the controversy for ACE and ARBs, for ibuprofen, then there are some people who say that this molecule is bad, this molecule is good. So we are picking up some pieces of the maze and projecting it as the evidence. But it is good to know that at least we do not have to discontinue statins in this people. There is a study which said that statins cause harm. So I don't think the final word is yet out, because it is like coffee. Coffee is good for health, coffee is bad for pancreas, coffee causes this, coffee causes that. So I think everybody is having a headache in trying to project their hypothesis, and depending on the hierarchy that they are, their hypothesis are accepted or rejected.
Thank you, sir. Thank you, Dr. Dr. Mittal, your comments on it, please.
Yeah, as Shashank was talking, I was trying to dig out. We've just analyzed 413 consecutive patients, moderate to severe, few mild, some healthcare workers, but bulk were moderate to severe. The data is not out yet. It's just a text message from my younger colleague that out of which 152 were diabetic. So which means that out of 35% roughly of the hospitalizations at our center, of 400, there have been so many, there have been thousands, but we just managed to profile 400 properly, actually did have diabetes. And although we haven't done, that has already been done, but I don't have it with me, quite clearly the outcome in diabetes is clearly worse. So that's one part. About the use of various drugs for diabetes, I think it is important that we realize that we don't have to make any major changes in treatment. At the moment, this is my sort of interpretation of the data. They don't have to drop any drug. This drug is causing harm. This drug could cause that. I would just stick with whatever controls the patient. The moment you move to severe cases, you obviously are on insulin infusions or basal bolus therapies and all that. It's a different story altogether. And if you move to steroids, then it's a nightmare, and we are really dealing with that every day. COVID per se is causing severe hyperglycemia, and then you give steroids, and then those patients. And let me make this comment here, because those patients after discharge, I mean, I've had patients for 2 months. I mean, now they're beginning to settle into their normal rhythm. These are not those who went in with A1Cs of 10. Those are the worst off. You start with an A1C of 10 and then you get steroids and all, then it's a different story. But even those whose A1C in March was 6.4, 6.1, and I'm still struggling to get them back down. It's taking a long time, and they're feeling miserable. And sometimes I feel that, because in their anxiety and all good intentions of trying to fix this disease, we are probably using a lot of drugs. And I don't know how much of the post-COVID is somewhat linked to our anxiety to treat our patients well with multiple molecules rather than any one. And therefore, I definitely feel that some of the effects that I'm seeing post-COVID are linked to just multiple drug usage to save a life at that point. The important point I will make, and most of the points about diabetes have been well covered, is that the concept that of a syndemic. And if you look at yesterday, I think Richard Horton wrote about it. But syndemic is a concept where you talk of not just a pandemic, it's beyond that. It's a pandemic of infection, which is taking a toll on the whole NCD system. So it's actually also a warning that if you don't manage your NCDs well, then you will get more and more effects of a pandemic like this. So which means that supposing it's a really bad scenario, there's no vaccine that appears, and we have to live like this for 3 years, maybe not just few months or 1 year, then we haven't focused on the NCDs, on our diabetes, hypertension, as we haven't. We have tried, countries have tried, India has also had so many efforts, but it's a huge challenge. So the issue is that the whole thing, if you don't have NCD, let's say, then you're not getting much affected by COVID. The outcomes are pretty good. I mean, I'm exaggerating, but by and large, you could say that. So to manage a pandemic, you need to manage NCDs first. That is the concept of a syndemic. And I think that's something that's a relatively newish word, but I think that's where we need to look at the overall connection between diabetes, hypertension, and COVID, and not just as a virus that has come and affected our patients.
Thank you so much, Dr. Dr. Ghosh, also something about COVID-induced pancreatopathy. What do you think? It's a new entity. It is going to stay. Right. Is it a form of stress hyperglycemia or something else?
Okay. Continuing from where Professor Mittal left off, the Calcutta Municipal Corporation, I've been actually working with them. There is 164 wards in my city. We've actually employed 8 people per ward to go door to door to try and identify people who have these comorbidities. So we are in the process of creating a registry of that, and we are providing a helpline number as well as a free teleconsultation and a free web consultation so that we manage their NCTs better. Management of comorbidity is very, very important during these times. And maybe diabetes per se is not that important, because the word diabetes actually encompasses a lot of things, not just the hyperglycemia. It could be diabetes-related kidney disease. It could be the diabetes-related heart disease. So all of that is actually making things worse. And if you look at the total number of people who've come into our hospitals with COVID, with diabetes, it's somewhere around 30-35%. But normal hospital occupancy, if you look at, has diabetes of 30-35%. So it's not that I think that the diabetics have actually, done very badly in terms, or maybe they are getting the infection more, but it's just that once they get it, because of the other associated comorbidities and the other problems of uncontrolled hyperglycemia, they might be having poorer outcomes. And the good news is that there is at least some data to suggest that irrespective of you having diabetes, if your glycemic control is good, if your comorbidity control is good, your outcome is same as someone without diabetes, without those comorbidities. So that's the positive bit of things to look at. And therefore, we've got to be aggressive. And like all of the previous speakers said, I think we've been trying to chop and change too much. Let them stick to what they were on what they were controlled on, if they were controlled on, rather than, saying, this shouldn't be used, that shouldn't be used. Of course, probably SGLT2 might be an exception in particularly an individual who actually caught the infection. Though Dr. Joshi was talking about the DARE 19 study. In fact, the corporate hospital that I go to is one of the centers for DARE 19 study of dapagliflozin. But that's still too theoretical for the primary care physician or the physician at large to think of the data. In terms of involvement of the pancreas and involvement of the liver, what happens to diabetes with COVID? Or what happens to hyperglycemia as a result of COVID per se? So 2 or 3 things have been postulated to happen. One, there could be a direct effect on the beta cell with beta cell dysfunction and people presenting with type 1 like diabetes. Fortunately or unfortunately, I haven't seen anyone like that as of now in this period of time. I've had newly diagnosed type 1s, but they have had the typical antibody positivity, low C peptides. Not that I have known that they've had COVID. I've even gone and done a COVID antibody to try and figure out whether it was related to COVID. I've not seen that. In terms of severe insulin resistance, yes, I have seen people who've come into the hospital because the steroid bit came in, the story came in late. Initially, not everyone was getting treated with steroids. But even at that point of time, I found significant insulin resistance in some of the patients. Absolutely. And like Professor Mittal was saying, even after people have so-called got well, the fever is gone, people have gone back home, things haven't settled down for everyone. Something's wrong somewhere. They're not feeling well. And the so-called post-COVID state, I know it's very vague and difficult for me to define, but people have not gone back to normalcy. And then if I look at people who I saw, say, maybe 3.5, 4 months ago, maybe they are now settling down. And I don't think I can put it down entirely to stress. Something has gone wrong somewhere. Maybe some data will come up later on to explain what went wrong where.
Yes, sir. Yes, Dr. Mittal.
Yeah, Rajiv, 2 important points. I think this is great because now we're really talking with a fair degree of experience about this condition as compared to 3 months ago. And I do think that I have 2 broad kinds of patients. They are the ones who are relatively free of comorbidities. A1Cs are well controlled. It's like a breeze for them. They don't even know. I mean, sometimes they have a 1-day fever, half-day fever, and you keep monitoring them from home. They put them under home care and they're fine, nothing. No. But the ones who cross that line, ones who go into moderate to severe disease are typically, I mean, there are exceptions, the statistics, but typically are the ones who are sicker and they get into quite a jam. And the other thing, I just got the data of those 15 who died in our 415 or 20 patients, 12 were diabetic. So I mean, the proportion.
What about the other comorbidities, sir?
We're looking at that. Yeah, of course, renal function.
That probably would be.
Yeah, but I'm just saying, I can give you some data, but it's all really WhatsApp data. It's not just being analyzed. 164 had hypertension, 152 had diabetes, 36 had established CAD out of 415 15 or something. 25 had known respiratory disorders. 12 had CKD, established CKD, like pre-admission. So we'll look at all that carefully. But just to give you a sense of what we are seeing. The studies on vitamin D, though, this is just ancillary data. Okay.
Thank you, sir. Thank you so much. So we shift gears. We get into the usage of flash glucose monitoring in ACS patient. Over to you, Dr. Sethi. Flash is a very powerful emerging tool, and HbA1c has been a very powerful surrogate marker. Now, at the EASD, they had the Liberates trial where post ACS they put a flash, and they found, though none of them was significant, but they found better time in range and lesser hypoglycemia. So do you think our monitoring post ACS will change with this kind of study? Will we be using more CGM on these patients? Dr. Sethi, for you, sir.
Okay. When the results were a bit surprising, that individuals were monitoring their glucose levels by flash glucometer did spend a shorter time in hypoglycemia and slightly longer time in range, but none of them reached statistical significance, which was really not very easy to understand. That means that if you are doing your self-monitoring of glucose in patients who are on secretagogues and insulin, you can put it the other way around. That's good enough. You gain about 71 minutes of target in range, and you had 30 odd minutes of less hypoglycemias, and the analysis were different. If you use some different model, then the data was showing slightly higher numbers. Otherwise, it is surprising. That means to say that something more is required other than monitoring. And typically, I am not blaming cardiologists again, though we are bashing all of them today. Is the person who treats those people is also important. A typical patient who is in coronary care unit who gets discharged might not have access to modification therapy, might be on insulin when he probably does not require it. There are many number of people, and there are good drugs now which cause no hypoglycemia, which can be given in this situation. So coming to the study per se, it was a bit surprising. Probably the therapy was also not modified as well. If you are modifying therapies based on monitoring, then only you will get some results. Otherwise, just like getting a logbook and having no intervention in the days gone by. So if you're having a flash data which showing that your target in range at 90 days is just 71 minutes more, I think that's disappointing. But what it means is that it requires greater amount of monitoring. And if you're monitoring it very well, you might be extending your time in range. The mortality data also numbers were too small. The deaths, I think, occurred in about 3 people in the intensive group and the flash group, and about 6 or 7, but the numbers were too small to compare. And then the MACE events were the other way around. They occurred more frequently in individuals who are on the flash monitoring. So I think there is too little of data here, but it looks like it's doable. And as it becomes a norm, which is unlikely to be the norm for days to come till it is available with a reader all the time, I don't think this data is very exciting. It stresses the need for monitoring, but the differences were not really statistically significant, and that was the most surprising part. Probably there was something wrong with the therapy. The therapy, if it has been modified based on that data, we would have had different results. That's my guess.
Thank you so much, Dr. Sethi. You compressed the entire study in a fantastic format. Dr. Mittal, a slight tweak to this, that would hypoglycemia, is it a risk factor or a risk marker for any kind of cardiovascular event? You know, we try to catch the dots or connect the dots and make hypoglycemia the villain everywhere. Is that a big villain? Do we need to put these kind of monitoring to catch it? Is an SMBG good enough?
So, well, how much of an impact the monitoring will have on endpoints will remains to be seen. I mean, that's pretty hard to show outcome data with that, but I'm sure someone will look at it. But of course, we know that hypoglycemia is deleterious. There's no question about it. When I was a resident, my professor used to tell me, in a cardiac patient, you shouldn't get hypoglycemia, whatever else you do. Okay, so there's really nothing new about that, but there's plenty of solid data to suggest that occurrence of hypoglycemia can aggravate, of course, in the acute stage, actually precipitate a coronary event, precipitate arrhythmias for that matter, but also recurrent hypoglycemias have a deleterious impact on outcomes. I think that's pretty well established. So I do think that one of the key things about managing diabetes, especially in a population with comorbidities and with other issues, is to avoid hypoglycemia. So where we have been using flash monitoring, for example, in a somewhat aligned but different, slightly different situation is, for example, someone comes for surgery from a distance of whatever, and is due for some elective surgery or some surgery, and you have to give a clearance and the sugars are all over the place. So you institute insulin, now you put him in the hospital, the costs go up a lot. So we institute insulin on an OPD basis and ask the person to, we attach one of the flash monitors, and maybe the patient can come every day even, because we don't have the readers for everybody. And you can take a download and you can, within 3-4 days, you can give a clearance for surgery. I have no data to scientific data, but I am in clinical practice. I have used that fairly successfully to bring glucose to a certain level where you can be confident that it's okay to go for a particular surgery or not. So that's one other way that we are using it. We also think that we have used it in post-CABG patients also when we are sending them off. If they're still staying in town and whatever for 2 weeks after the surgery, post-transplant on steroid, we have used these with varying degree of success, I would say.
Thank you so much, Dr. Miller. Dr. Sujay Ghosh, your take on this?
Right. I would agree with Professor Mittal that, we have always been taught that hypoglycemia is a risk for cardiovascular event. But again, to put a spanner in the works, if you look at the linagliptin glimepiride study, Carolina,
no difference.
You had more hypos with glimepiride, and yet you were not able to kill more people with glimepiride, which was assuring, at least in a country like India. I think the major problem with this particular study that we are discussing, Libre, is the methodology and the patient selection. Now, you've taken people who are post-ACS on sulfonylureas and insulin, and you are expecting that people will have more hypos, and that hypo will kill people. Now, this would have been a good study if you had people who have, brittle kind of diabetes, insulinopenic diabetes, people with bad kidneys. Because I don't think we still have access to the full text of the article. But if you look at that group of individual, that would make them susceptible to hypoglycemia. Whereas standard someone who had some degree of hyperglycemia, relatively well controlled with say 1 milligram of glimepiride or 2 milligrams of glimepiride, I'm not going to make a huge difference in the glycemic control. I'm not going to increase the huge risk of hypoglycemia. Someone on basal insulin, otherwise okay, I'm not going to make a big difference. And therefore, I think I would like to have a closer look at the trial design and whether, it was powered enough to, have those so many kind of hypo events in the first place. And then that hypo event translating into cardiovascular event, it's a long shot.
Absolutely. So, sir, I'm going into a rapid fire round. We've got like 5 or 6 minutes. So two questions, half a minute answer. So one which was presented was that GDM were followed up postpartum. They had 41%, which is fantastic if as far as India goes. And there are 2% people who were developed diabetes and 17-18% with pre-diabetes. So do you think that that's a window of opportunity for all of us? Should we have guidelines where postpartum GDM should be followed up and they should be properly so that we can prevent diabetes in them? We start with Dr. Ghosh.
I think the guidelines are there. The data is there. The evidence is there. It's about implementing.
Absolutely.
How you implement what we know is the biggest challenge in NCDs. We've got to figure out a way for our own country in some manner so that we can actually implement the knowledge that's already there. I think that would be my take.
Thank you so much, Dr. Sethi, your take?
Yes, it's the problem of implementation. There are factors of nutrition, infant feeding, mother-in-law, mother, social factors. These are more important. The girl in question is very keen to do. Your husband is a peripheral issue. He just creates and goes away. But the problem is that these people are like pre-diabetics. We tell many people, say, had I known, I would have done this. But pre-diabetics and gestational diabetics who know for sure that they'll get diabetes, they do nothing about it. And it's most frustrating to see these people coming after 2-3 years saying that you had looked after the previous pregnancy, why didn't look after me now also? So, but this is a common trend. Unless this changes, and this involves, I'm not joking, many social, medical, and also factors between the nutrition, the obstetrician, and also the endocrinologist. The people who are on our follow-up, and there would be very few people. They would think at least the recommended test may not be thereafter, but at least after 6 weeks. But what happens afterward? They just lost a follow-up till they become pregnant again.
So I think, Rajiv, this is an important area, even more important area for India. Because if you look at the statistics of GDM in India, they're appalling actually. And the global figures of 10% and all don't apply anymore. Newer studies are showing, I was reading the other day for some other meeting at 26%. And there are smaller studies have shown even 35, 40%. I don't know what to make of that, but definitely even the WHO gentleman said that 25%, 26% probably is GDM. Now, that is a huge number. That's one part. The second part is one of the studies that I reviewed as a reviewer many years ago, 3 years, 4 years ago, clearly showed that at 6 weeks, if you did a systematic glucose tolerance test in everybody who was discharged at 6 weeks after delivery, you would find that almost 20% are pre-diabetic at that point. So that's a huge population. And actually, in this particular study, and I can send it to you if you like, 6.4% already had diabetes. So, and these were not known. I mean, we don't have a very good history of the past, but they were not known diabetics. So what I'm saying is that it's there, and there are so many challenges that Dr. Sethi said. It's exactly the same experience across the country. I think it's critical for us to get into this zone, emphasize that every GDM is going to be, we should say every GDM is going to be a diabetic, unless they take precautions. That's what I tell them, So that's my take on it. Bipin saying something.
No, I think Nick has already done some work called the Bridges study, wherein they found that at 1 year, 30 to 40% women were diabetic already.
So
5 years, that 50% people are diabetic. And they are doing that in terms of maternal counseling, family counseling, and there is study going on already with them. So the data is really, really appalling. And if it can be implemented, as Sujay said, I think implementation is a problem, and we need to work hard on this.
The wing study, I think you're talking about. Anyway, yeah.
So we go to the last question, again, rapid fire. We all know that, ethnicity loads the gun and we pull the trigger. So there was an article which said that ethnicity and obesity in early onset type 2 diabetes, a retrospective study, showed that Asian Indians are diabetics at a younger age with lesser BMIs compared to Caucasians. We all know that, but retrospectively means it's getting more and more, it's hitting on our face that we are younger with diabetes. We get
Lost you, Rajiv. Hello?
I can't hear you.
You suddenly lost you. It's a signal to back up.
His video has been paused.
Yeah, I think signal problem ho gaya udhar.
Maybe if 1 hour is over, or more than that is over already.
Yeah.
The duration is over.
He's
back. Yeah. Your take on this. Could you hear me? Could you hear the question?
Yes, now we can.
Sujay, your take on
right.
ethnicity and obesity.
Okay. I think it's to do about your traditions, the culture, the way you were brought up over centuries in terms of your diet, your exercise and lifestyle. So if you look in India, we go to KFCs and McDonald's thinking that it's a great place to go to. And if you go to, say, United Kingdom, that's where people go to save money because, and in India, you'll find that the rich are fat. And in the Western world, you will see that the rich are thin. So I think it's about cultural shifts which happen, perhaps more than the genes and more than the ethnicity. That's my view. That's probably the reason, because we've suddenly changed our lifestyles, we are now in that zone as Southeast Asians that we are getting more and more of these non-communicable metabolic disorders. Over a period of time, as we get wiser, as our, as we as parents, or maybe the next generation as parents, realize that, putting on weight is not a good thing. The food that you are eating, the junk that you're eating is not good for you. Probably that will change. And I think it's got to do with the economic background and the social background rather than pure ethnicity.
Thank you so much, Dr. Shetty. Dr. Mittal, your take?
Yeah, I mean, I think too much is made of ethnicity here. Yes, it's there. There's no question that ethnicity, but the genesis of that ethnicity induced effect is not just the ethnicity. It's not something in the gene. At least you don't have proof of that yet. And I think it really is very much a lifestyle issue. And as you very rightly said, in the US, we used to say that the Indian middle class is now like the US lower socioeconomic status. Exactly the same way we are going in terms of disease. And even in India, the upper socioeconomic class is very careful and very conscious now about their health. So it's a shift cultural. At the same time, you cannot ignore the centuries of deprivation that our bodies have been subjected to, with low protein diets and kids being born of malnourished mothers who have high amount of body fat and low amount of lean mass at birth. And when these are exposed to the energy dense environment that modern world brings with it, then they can't handle it. So this is, I think it is more you can call it a thrifty gene hypothesis. You can call it a cultural change. I think it's much more that than directly in our genes. That's my feeling. I may be proved wrong later, but right now I think that is much more likely.
Thank you so much, Dr. Mittal. Dr. Sethi, your take?
It's just slightly different. If you just listen to the lecture, Golgai lecture was very interesting. They tried to show that the Asians, compared to Europeans, have got genes which produce more insulin deficiency kind of syndrome rather than Caucasian, where there is something to do with lipid oxidation and insulin resistance. So there is some genetic factor, and they very elegantly proved that both resistance and deficiency are required. So if you are born with some kind of genotype which is likely to make you insulin deficient because the cells cannot, rise up to the challenge, then as what Sujay said and as Mittalji said, you're not going to have that compensatory hyperplasia sufficient enough to overcome this insulin deficiency. So I guess both the factors are there, but I agree. Genes have not changed in the past 30 years. Environment has changed vastly in the past 20 years. And this epidemic is possibly more to do with the environment than the genes alone.
Thank you so much, Dr. Sethi. I think in 1 hour, we had a condensed EASD and it was fantastic discussion. Who says we have to go to Austria or we have to pay 150 euros for the EASD when you can get everything in 1 hour? Thank you so much, Dr. Mittal. Thank you, Dr. Ghosh, Dr. Sethi. And I think Dr. Shashank has left. Over to you, Dr. Agarwal, for your concluding remarks.
Thank you, Rajiv, for doing a great job.
You so much.
Very, very nice. Yeah.
Thank you very much. Thank you. Thank you.
Opera now.
Thank you, sir. Thank you very much, sir.
Good to be in.
Sir. And it was really, indeed a wonderful session, sir. And as you said, Dr. Kovic just said in the start of the session, conducted within 24 hours of the EASD meeting. So, and I hope definitely it will help our audience to learning something new, definitely. Like you said about the importance of weight reduction. We learned about COVID-19 management, especially for the diabetic patients. So definitely these are few things, definitely our audience is going to learn. With the permission of the panel, so is there any time to take 1 or 2 questions? There are questions, on the link. So that is why. So I'm just asking permission. If you allow, then only.
I think this was more like a panel and this was more discussion. I don't think that we were the primary investigators in these studies or we were, so it's not that. So I don't think it is fair. We are only analyzing others' works and sharing some experience. So and it's not really a lecture. So perhaps it's not a great idea right now.
Okay, sir. No issue, sir. And again, sir, thank you for giving your time, sir, precious time for this discussion. And thank you very much, Dr. Sujoy Ghosh, sir, Dr. Amish Mittal, sir, and Dr. Shashank Joshi, sir, and Dr. Vipin Sethi, sir, who just left because of some other appointment, I guess. And definitely thanks to Dr. Rajiv Kovic, sir, for beautifully moderating this session, sir.
Thank you so much.
Thank you all.
Thank
sir.
you, everyone.
Thank you.
Bye-bye, sir. Bye-bye. Bye-bye, Sujay. Bye-bye, Dr. Agarwal. Thank you so much.
Thank you, sir.
From here, okay.